Right, welcome to the 9th talk in the neurology series. This one's on Parkinson's. Parkinson's originally was known probably as a state called Kampavata. Perhaps a 1,000 years ago, or I think it was probably longer than that, the Indian sage Agnivesha described this state, and it was basically a state associated with difficulty moving, a love of solitude, daytime drowsiness, and a mask-like stare. So Agnivesha was one of the sort of founders of traditional Indian medicine, Ayurvedic medicine, and he described this in a number of people, and he may have been referring to Parkinson's. After this, Kampavata became known as the shaking palsy, and this is what it's been known as for most of its history, actually. Most people have called what we call Parkinson's the shaking palsy. And this was described by physicians in ancient Mesopotamia, Egypt, and China, various different physicians who documented this. And even in the works of Da Vinci and Shakespeare, one of Shakespeare's plays, King Henry VI, asks, there's a character that says, "Why dost thou quiver, man?" And the fellow responds, "It is the palsy, not fear, that provokes me." So Shakespeare was talking about probably a guy with the shaking palsy or Parkinson's. And it was only 2 centuries ago that James Parkinson, an English apothecary, like equivalent of a pharmacist, sort of, wrote the most comprehensive description of the shaking palsy to date. It was just a case series of 6 people, and some of them he just went up to them on the streets of London and started talking to them because he was a spot diagnosis and asking them about the symptoms. Then he just wrote up a little case series. The beauty of the case series was it was the most comprehensive description of Parkinson's to date, and so that's what got people excited. If you did a case series today on pretty much anything, it doesn't get much notice, but times were different then. It was not named after him until several decades later. The great French neurologist Charcot named it after James in honor of his paper. Parkinson's is basically neuron loss, as is any neurodegenerative disorder. So for some reason, neurons in certain parts of the brain start to die, and each neurodegenerative disorder just has a different pattern. But probably the process is quite similar amongst them all. So we have these things called, we often have abnormal proteins in a neurodegenerative disorder collecting inside or around neurons. In Parkinson's, it's this thing called the Lewy body. We don't know what they do. Are they causative? Maybe. Are they a protective response? Quite possibly. Are they just sort of bystanders? Maybe. We don't know. The neuron loss occurs in a certain pattern, and the clinical symptoms mirror this. So neurons in the nasal and enteric neurons are hit first. They die first. And so that's interesting for a number of reasons, but by the time someone's diagnosed with Parkinson's, they've lost the majority, for example, of their dopamine-producing neurons in the gut, like 90% of them. Then it seems to travel to the brainstem, lower than mid, then upper. And this is where the sleep gets involved, hitting the lower brainstem centers, and then in the upper brainstem centers, you get the substantia nigra involved, the movements start to appear, movement disorders. And the neocortex really gets hit at the end most of the time. So that's why cognitive things like dementia and that can occur in Parkinson's, but they occur relatively late, at least in severe form. There's a different disorder called Lewy body dementia where the neocortex can get hit early on, but that's probably it's not Parkinson's. So Parkinson's, basically, it's best to think of it as a process that culminates in widespread neuron loss throughout different parts of the brain and body. And probably there are other non-neurons, other cells in the body that get hit too. For example, the white blood cells in people with Parkinson's don't function normally either. So there may be a more widespread thing going on. What could that widespread thing be? Well, there's various possibilities, but one, we know that the microbiota gut-brain axis is disturbed. So there's this sort of connection, many different ways that they connect. The bacteria that live in the gut with the gut neurons themselves, which connect with the brain through the vagus nerve. And there are other ways that these systems interact, so chemically and so on. This three-way sort of system is maintained, probably maintained, and each of the three levels influences each other in a very important way. It's altered in Parkinson's. It's very much different from people who don't have Parkinson's. What that means, we don't know. The enteric dopamine-producing neurons are 90% lost at the time of diagnosis, like I said. There's also mitochondrial dysfunction in the brain, and probably elsewhere as well. The mitochondria are structurally very abnormal looking, and their complexes, their electron transport chain, are really damaged. Complex one the most, the others to a lesser extent. And so that strongly implies that they're not functioning correctly either. So mitochondrial dysfunction is a very universal feature in Parkinson's disease. So maybe these two things are playing a role in the pathogenesis somehow. The diagnosis is strongly clinical, and it involves multiple symptoms, since it is a disorder of widespread neuron loss. So we often talk about the four motor symptoms. This is what we learn about the most, I'd say. Tremor, bradykinesia, rigidity, postural instability, largely related to that little area circled in red there, the substantia nigra in the brainstem. But there are non-motor symptoms that actually dominate the clinical picture, and that's, you can see all these other things. So the rest of the brain, a lot of it takes a hit, and then you've got various components of the nervous system that are dysfunctional elsewhere. They are more insidious. The patient may not volunteer them because the tremor, the movements sort of dominate what people see and pay attention to, but these actually affect quality of life more. So sleep disruption, mood disorders, autonomic dysfunction, enteric dysfunction, pain, and cognitive impairment, 6 categories of non-motor symptoms that you'll know about pretty well by the end of today. And in general, just remember the non-motor symptoms negatively impact quality of life more than the motor symptoms. So it's worth addressing them. Okay, so anyways, the motor symptoms, tremor is about 80% prevalent. Not everyone with Parkinson's has a tremor. It's in Parkinson's, I'm going to say always. It's dangerous to use that word, but it's pretty much always one-sided at the start for the first few years. One arm, one leg. And it's described as a pill rolling tremor. So you get this pill rolling of the thumb on the fingers, and you'll get a bit of supination, pronation maybe as well. So it's worse at rest, classically, and it can also occur in the lips, jaw, or leg. It doesn't involve the neck. If you have a neck tremor, it's almost certainly not Parkinson's. It's probably something called a dystonic tremor, which is another kind of movement disorder. Bradykinesia is the second thing. This is pretty much universal. Now, bradykinesia is not slowness of movement solely. And in fact, it's not even that specific for slowness of movement. Some people with Parkinson's can move kind of fast. It's a reduction in amplitude of repeated alternating movements, mostly in the symptomatic arm. So it'll be unilateral at the start. And a common test we do is finger tapping. So you get them to do 10 taps, and as they do the taps, it's not that they're moving slowly, it's that the amplitude gets smaller. That's true bradykinesia. And you can do the same with fists, and the amplitude will get smaller. They could be pretty fast, but then they get smaller. So that's, if you don't see that, be very careful about making a diagnosis of Parkinson's. Rigidity, so they get unilateral stiffness, objective tone increase, and of course all these things become bilateral with time, with years, but not at the start. And you get cogwheeling at the wrist. Postural abnormalities, there are many, so this is the gait basically. Capricornia, which is that stoop posture shown in the picture. Reduced arm swing on one side, that's a very distinctive sign and probably the earliest. They don't move one arm as much as the other. Small shuffling steps, en bloc turning, so taking a lot of steps to turn around. Hesitation, freezing, festination, and so on. So festination refers to a increase in the pace and a decrease in the amplitude of the steps as they walk. So they'll actually start to walk faster, smaller steps, and they might get top heavy and fall forward if there's nothing there to stop them from falling forward. Now, tremor examination is really useful, not just for Parkinsonism, but for many things. So It's basically sort of a 4 or 5 step tremor exam that it's very good to know if you're examining one of these people, particularly for the short case exams and the basic physician trainees. So first I get a patient to sit, arms on lap, and just see if there's a tremor in the upper limbs while they're at rest. And if there is, well, Parkinsonism is a strong differential. And then you get them to do two postures. So I get them to sort of push their arms out in front of them and just for a few seconds and see if a tremor appears. If there's something called a re-emergent tremor that appears after a few seconds, which can suggest Parkinsonism as well. And then you get them to do another posture. I like to get them to point their arms at each other without touching. And same thing, you get to see if there's a re-emergent postural related tremor. You do your finger nose test. So this is really looking more at the cerebellum. And of course, we're most interested in what we call dysmetria, which is a difficulty with timing movements. So usually they'll overshoot or undershoot. So hypermetria or hypometria, we call it all dysmetria. Overshoot, you want to see if they overshoot the finger, the target that you give them, or they undershoot. Usually overshoot is more common, and that suggests a cerebellar disorder. And you might see an action tremor associated with that, and the action tremor would be associated with a cerebellar disorder more than Parkinson's. And then there's a fourth task step, which is very important. That's performing a task. This is looked for something called a dystonic tremor, which is actually quite common and often missed. And this is a task-specific tremor. And the patient will tell you, it gets worse when I try to drink coffee or something, or it gets worse when I try to do a certain task, maybe writing or whatever. And you should just examine a couple tasks, the ones relevant to the patient, to see if that's present. Essential and functional tremors are sort of the fourth and fifth most common. These are the 5 most common tremors in general, in no particular order. The essential tremors and functional tremors can appear in any of these steps, really. The functional tremors, I would add an entrainment test onto the end of my exam. I wouldn't normally do it unless I strongly thought it was a functional tremor. And the entrainment test is on, I think, the third talk of the series where I go over that. Okay, so you can also do an examination if you think someone has Parkinsonism. Parkinsonism doesn't necessarily mean Parkinson's disease. Parkinson's disease is the most common cause of Parkinsonism, but there are others. So what you do is look at the gait. So again, you're looking at that Parkinsonian gait. You need to see all these features that we showed in the previous slide. Face and eyes. So you want to look to see if there's a lip or jaw tremor. Masked facial expressions, so difficulty displaying emotion in the face is very common. And there may be a vertical gaze palsy in Parkinson's. Some of the cousins of Parkinson's show this more, particularly one called progressive supranuclear palsy, or PSP, often has a vertical gaze palsy. You look at the upper lower limbs. So you want to do a tremor exam, like we just mentioned. You can check for bradykinesia, very importantly. You can do finger taps or fists. Maybe if the lower limb is more affected, you can do foot stomps. And you can check tone by see if there's any rigidity. I always check on blood pressure at the end, because if they have a drop in blood pressure on standing that's significant, like over sort of 15 millimeters of mercury or so, then that could be supportive of Parkinson's. There are other mimics of Parkinson's that can cause this to a tremendous degree. There's one called multiple systems atrophy, or MSA, that does this very strongly as well. So that's the Parkinsonism examination. And if you're doing the short case exams, doing that with a tremor exam thrown in can take you like 2 minutes, and it can be very effective. All right, so now we'll look at a few patients and just show you some examples of this. So here's an example of early stage Parkinson's disease. So what you notice here probably is just a very subtle reduction in the left arm swing, I'd say. And maybe that left arm looks a little stiffer. This guy's more apparent, so the left arm's not shaking much at all. See? Gait's pretty okay otherwise. He might have a bit of camptocornea, he's a bit stooped. This guy, it's even more apparent, so that left arm's really not shaking at all. Watch how he turns, it might be a little slow. Oh, they didn't show it. Okay, so those were sort of milder cases. This is milder to moderate. So you can see probably both arms are swinging a little bit less than they should be. And he's quite stooped. But you can see how the arm swing is very important early feature of these gait disorders. This guy's a little more severe. He's probably fascinating a bit. If we get him to walk longer, he might start taking quicker and shorter steps. This lady is on the more severe end of the spectrum, so she's got quite small, probably shuffling steps, very reduced arm swing. She took a while to turn around there too. Bit of en bloc turning there as she tries to sit down. This guy has serious trouble with freezing. So they're trying to get him to do multiple tasks. So holding this tray or doing multiple things, basal ganglia are necessary for chunking individual movements into automatic repertoires. So they allow you to do complex movements without thinking about them. That's why these guys, walking's a complex movement, and now we've thrown in the tray, and now it's too hard for the basal ganglia because his are damaged, and now he's freezing. On another one. So many variations on the theme. A lot of hesitation and freezing here. Can't even get going. There are tricks, strategies and stuff you can help people with to get them to go in the clinic. A lot of them are mind-related imaging strategies. Okay, so now we'll have a look at this one. Okay, so when you first look at someone, you want to do observation. And this guy's just sitting in a chair, but you can see that he's probably got a slightly masked facial expression. Look at the left upper limb. It's slightly tremulous at times, just a little bit. And they've given you some other things that you can look at. He's got a reduced eye blinking, rate of eye blinking. Kind of seems like a lack of spontaneous movements. Now we're going to demonstrate bradykinesia. So she's saying, you're looking for smaller and slower changes over time, at least 10 reps. Smaller is the more important. So there's the finger tapping test. See how he does. And you can see that he's pretty fast, but he actually, that's his good limb, pretty fast. The left limb's not as fast, but still pretty fast, and it gets smaller. That's the key thing. See how the amplitudes get smaller. So that's really all you're looking at. Simple test, very effective. Okay, so non-motor symptoms. Now that's the motor symptoms. Non-motor symptoms are equally, if not more important. So 6 categories. The first is sleep. Sleep is so crucial, and it's virtually universally disrupted in Parkinson's. They present with insomnia, and there's 2 kinds of insomnia on a basic level. Difficulty falling asleep versus difficulty staying asleep. Can be one or both. This is extremely common. REM sleep behavior disorder is extremely common. Between the two of these things, it's pretty much every single person with Parkinson's. A REM sleep behavior disorder is where they talk or kick or punch out in their sleep. You're not supposed to do that. You're supposed to be paralyzed in your sleep, particularly in your REM sleep when you're dreaming. Daytime drowsiness occurs. Even if you get their sleep good, people with Parkinson's still can be drowsy during the day. And they are more prone to restless leg syndrome, which is an uncomfortable urge to move the legs. Mood disorders is the second category. These are the 2 biggest problems with the motor symptoms, the sleep disruption and the mood disorders, because they affect quality of life so much. At least 50% of people have depression or anxiety, or a bit of both. It's probably a little more than that. Depression, as you know, low mood, loss of pleasure, feeling worthless. Anxiety is excessive worrying. social phobias, panic attacks, and both of these things can manifest in different ways. Extremely important to look for them. Pain is at least 50% prevalent. The most common pain syndrome in Parkinson's is musculoskeletal. It's like a frozen shoulder, which is the most common thing. It's the Parkinson's. It's not necessarily a structural thing. Same, second most common is radicular pain, like sciatic pain. They may have a disc herniation as shown in the picture, but often in Parkinson's, the imaging is pretty normal. And a third thing is a dystonic pain syndrome, where usually it's an ankle inversion or a toe curling, sustained contraction, and dystonia, which is a sustained contraction. It can be very painful and often hits them. All these things hit them when their levodopa is low. Autonomic dysfunction is very common in Parkinson's, so postural hypotension, systolic drop, at least 15 or 20 millimeters of mercury, loss of urine control, resulting in a whole variety of symptoms, erectile dysfunction in men, and excessive sweating. These are all pretty common too. Enteric dysfunction, at least 80% prevalence, probably more if you look carefully. So people, the most common symptom in Parkinson's is loss of smell, about 95% of people. So loss of smell, constipation is about 80% maybe. And so both of those are probably more common than the tremor. And the sleep disruption is more common than the tremor. So the tremor is not the most common symptom with Parkinson's, even though that's what we think about all the time. There's dysphagia, which is very mild, but present in a lot of people, the majority. Becomes a problem later on. Sialorrhea, because of the dysphagia, they don't swallow the saliva. We unconsciously swallow our saliva all the time. People with Parkinson's, they don't do that. So it just builds up. And you can get other things like bloating. Cognitive impairment is a late-stage thing, and this can manifest as hallucinations, delusions, or illusions, apathy, disinterest, indifference, dementia in its latter stages. So you can see the non-motor symptoms are many and varied, and they can really hammer quality of life hard. So this is Parkinson's. Don't just think of the movement disorder. Now, that being said, there are mimics of Parkinson's, a couple of which I alluded to. This is the mimic octopus, which is my favorite animal, because you can see on the left, it can change its appearance to look like, I think, at least a couple of dozen different animals to a fairly good extent, such that it can trick other animals. So Parkinson's plus syndromes is the first set of mimics to think about. There's three major ones, the PSP, MSA, and the last one is cerebral, is a corticobasilar syndrome, or CBS. The first one gives you vertical gaze palsies and early falls. They present with falls. People with Parkinson's don't present with falls. The falls come later, if they come. MSA presents with autonomic dysfunction and cerebellar ataxia. There's a variant that's ataxic. Some of them present more with Parkinsonism, some with more ataxia, some with a bit of both. The CBS will present with apraxia, alien limb syndrome, where usually an arm will be sort of doing things and the patient's not really aware of what the arm's doing, and they can have frontal deficits. So these are all important to consider. Lewy body dementia is another differential. This is the reverse. So rather than the dementia coming at the end, it comes very early on. So if someone's getting really cognitively impaired and they got Parkinsonism, don't really think about Lewy body dementia. The other things are they get fluctuating cognition throughout the day, so they'll be more aware at times and very much less aware at other times, and visual hallucinations is a prominent feature. Normal pressure hydrocephalus, have a guy in the ward now who we're sort of looking at. He's been diagnosed with Parkinson's for 7 years, pretty sure he doesn't have that, pretty sure he's got NPH. And NPH presents with Hakim's triad, so you get cognitive impairment, urinary incontinence, and a magnetic gait. It's kind of like small shuffling steps, but it looks like the feet are sort of like they got magnet boots on. They're sort of glued to the floor, so it's a little different from the gaits we just looked at. Other mimics include vascular Parkinsonism, so you could have multiple strokes. If enough of them hit the basal ganglia, maybe you can get some Parkinsonistic features. Medication-induced Parkinson's, particularly antipsychotics and antiemetics, can cause this, so the treatment is fairly straightforward. And you can have another tremor disorder that can kind of look like Parkinson's. If you do a proper tremor exam and so on, you shouldn't get fooled by these. But essential and functional tremors can, particularly functional syndromes, they can look very much like Parkinson's. So just be aware of that. But these are pretty rarely misdiagnosed. So with Parkinson's, take a corroborated history, ask about loss of smell, constipation, and sleep, and ask the wife or husband, Most people that get Parkinson's are men, so it'll usually be a wife. Those are more common than the tremor. Then ask about all the motor and non-motor symptoms that we went through, because if you don't ask about the non-motor symptoms, many of them won't be volunteered, and they actually impair quality of life more. Check red flags. So look for things like early falls. That would lean you more towards PSP or maybe MSA. You get falls with MSA because of the postural blood pressure drops. If they have early cognitive decline, consider something like Lewy body dementia. Check for antipsychotics and antiemetics. Obviously, those can produce Parkinsonism. On the examination, I really focus on the tremor and Parkinsonism examinations. They're very good, very quick, and they give you a lot of information. And brain imaging, I do a CT head in pretty much everyone just to make sure we're not missing a stroke-related Parkinsonism or normal pressure hydrocephalus. But sometimes you might want to get to an MRI, but I think a CT head is adequate for pretty much everyone. And I do it as a one-off. I don't do it anything else for any other reason. It's to exclude mimics. Parkinson's is a clinical diagnosis. Do you need the CT head? That's even debatable. Treating Parkinson's, there are numerous options available. So the first is dietary modification. The second is exercise regimens. The third is medications, and then we can get into advanced treatments. People with Parkinson's really appreciate you going over the first two. For some reason, people with this disorder are even more interested than most patients in non-medication-based strategies. So it's very much worth your time to know a little bit about the first two. Dietary modification. Now, the evidence for this is mainly from observational studies, right? So not interventional trials, which is unfortunate because observational studies can show you correlations but not causation. So one thing that often surprises people with Parkinson's and people in general is that coffee is something that people with Parkinson's don't consume a lot of. And the association is very strong. It's been validated in many different studies. So people with Parkinson's don't drink a lot of coffee. Same in Alzheimer's. And the association doesn't seem to hold for decaf. It's got to be some caffeine in there, something good. To a lesser extent, people with Parkinson's also consume, people without Parkinson's consume more tea, red wine, veggies, fruits, seafood, seeds, nuts, olive oil, and coconut oil. So, does that mean you can recommend all these things to your person with Parkinson's? You should drink more coffee, you should have more red wine, you should have more seafood. Not necessarily, okay? But it's something to be aware of. It's nice for them to know and just say, look, these are the associations. Conversely, people with Parkinson's consume more of these things. The most common association is canned fruits and vegetables. And some people have said, oh, is there something in the metal of the can that's causing a problem or something like that? We don't know. Again, it's just an association. Sodas, fried foods, beef, ice cream, yogurt, and cheese are all the things that people with Parkinson's have more of. So I think it's very important to be aware of these correlations, but don't you can sort of speculate on causation from here, like, it might be a good thing for you to knock off the ice cream and fried foods and maybe punch up your vegetables, for example. That seems logical and commonsensical, but you can only take the evidence so far here with these studies. So we need more interventional trials. Interventional trials are unfortunately scarce, but these are what allow you to infer causation. If you have two groups, you treat one with one treatment, the other with another treatment, everything else is kept the same, and you follow them, and one group gets better, well, it was almost certainly, if you did the experiment correctly, due to your treatment, right? And then you can say that caused that. So there's a couple RCTs I'll just mention. So yes, a Canadian group did do an RCT, randomized controlled trial, of caffeine versus placebo. And they used tablets, and they did 60 patients for 6 months, which is good numbers and a good length of time. They didn't find any differences. I guess the only criticism you might say, maybe they should have tested real coffee, because coffee has a lot of good stuff in it. It may not be just the caffeine. It may be something else that's in the coffee. We did one here 4 years ago now, hard to believe. RCT of a low-fat versus a ketogenic diet. So a low-fat diet was neither of them had, the keto diet had almost no sugar. The low-fat had very little, lots of fiber. Good diets, you could say, for both of them. The low-fat was low-fat, high-carb. Keto was high-fat, low-carb, kept the protein the same, and saw what happened. So we did this in 47 patients for 8 weeks, and both groups actually improved, probably because they were both none of them were having ice cream anymore, or beer, or fried foods, or any of that stuff that I mentioned. Both of them were on better diets, but and also because we gave both of them a better diet, there could have been a little expectation of benefit in both groups. Placebo effect, have to be careful of that. But the keto group improved more, particularly in the non-motor symptoms, a lot more. So 41% reduction in non-motor symptoms, so cut almost in half, which is significant. You think about all those non-motor symptoms versus 11% in the low-fat group. So that was very much a statistically and clinically significant difference. Maybe a keto diet is the way, but we need more interventional trials. Exercise regimens. These are really important in Parkinson's too. This evidence, if you look at RCTs and then sort of collectively analyze them, is best for these 6 therapies, I would say. Treadmill exercise, it's not the cardio benefits, it's more the postural training and sort of timing benefits of being on the treadmill. Aerobic exercise, again, same thing. Probably a lot of the benefits come from the balance and timing component of the aerobic exercise rather than the cardiovascular benefits. Resistance training is very good, same argument. Dance therapy, Tai Chi, and boxing. These are all validated in good trials. And in Waikato, we're blessed because these are all available in Hamilton for people with Parkinson's, so special groups, people who are able to instruct people with Parkinson's in these with other people there in the class, except Tai Chi, to my knowledge. I don't think we have one of those. Ben might know, but our Parkinson's nurse, Ben, but to my knowledge, I don't think we have a Tai Chi one, but I might be wrong. Medications. Now, got to know about the medications. Obviously, although we rely on them too much, they are still a backbone of Parkinson's. There's no question. Always important to remember they temporarily mask symptoms. Okay, so Parkinson's progresses every year a little bit, like 1 to 2% of the neurons are lost. Your medications are trying to replace dopamine or stimulate the receptors, dopaminergic medications in some way, compensate, but they don't actually fix the neuron loss. Okay, so that's important to know. Levodopa is by far the best. This comes in various brand name forms, Cinnamate, Mad Parkinson. So it's basically dopamine with carbidopa or benserazide added. And that additive simply prevents the dopamine from being broken down too quickly in the blood, so it has some time to act. It has a marked therapeutic effect. It's really the best thing we have, medication-wise. Adverse effects are moderate, I'd say. So nausea and postural hypotension can happen. And the later ones that are more bothersome and become an issue are the motor fluctuations and dyskinesias. So motor fluctuations means they start to get a reduced duration of effect. So you might get sort of 6 hours out of your Cinnamate, and then after a few years it's 5, and then it's 4, and then you might be fluctuating very quickly from hour to hour, even shorter. Like you're getting a really good medication effect, and then you're frozen back and forth. That becomes a problem. Dyskinesias are also a problem. So when someone has the medication on board, we say they're on in quotations, and when they're frozen, the Parkinsonism is coming out, we say they're off. Now, dyskinesias means someone's on, but with medications, with time, people can get a hyperkinetic, so too much movement disorder. Remember, Parkinson's is a not enough movement disorder, a hypokinetic movement disorder, and they can get these funny ongoing movements of the arms, the legs, and various parts of the body. Usually doesn't bother the patient much until they're severe, but it can be bothersome in a social context because they become self-conscious. There's 2 forms of levodopa, immediate and controlled release. It's really important to know that these are almost, I see them almost as 2 different medications. The first one is almost entirely absorbed. It takes 30 to 60 minutes to go to its peak effect, and it lasts for 3 to 4 hours. The latter, the controlled release one, is only 2/3 absorbed, and it takes up to 2 hours to get to peak effect, but it lasts for up to 6 hours. So I'd say it lasts a little longer than that in most people. So they're very different, and you can see that where one might be really good, the other one might not be, and vice versa. And basically, I like to use immediate releases during the day, and right before someone goes to sleep, it's good to throw in a controlled release. And what you do actually is you give them an immediate release an hour before they want to go to sleep, because the immediate release will work within 30 to 60 minutes. When when you sleep in Parkinson's, you need just as much levodopa as when you're awake. Otherwise, sleep will be disrupted. So if you give this an hour before, that immediate release levodopa will be working at a high level an hour later, and then they'll go to sleep. You optimize their chances. And then at that point, when they're starting to get drowsy, you say, take the controlled release. The controlled release won't do anything for a couple hours, but then by the time midnight comes around, it'll kick in, and it'll keep them going till like 6 a.m. This is a very effective strategy for sleep. It's amazing to me how it's not utilized more. It's extremely effective for addressing sleep. And trust me, if you can improve sleep in Parkinson's, you've done that patient a big solid. Any protein interferes with absorption. So what I always tell patients too is, if you got enough protein in there, it competes with levodopa for absorption. And so there's no point taking it with a meal. You should take it an hour, I would say at least an hour before or after any meal. Better before, probably, before there's any food in there. And only take it with water so that you don't have protein interfering. You will maximize, usually when Sinemet starts to fail, it's not just that the Parkinson's is progressing, but it's that the Sinemet administration has not been timed correctly. The incorrect forms have been given. They're not focusing on sleep. These are easy things to do, and you can really make a huge difference by doing this. Dopamine agonists. Now, these are good and these are bad. They're not one of my favorite medications for Parkinson's. In New Zealand, we use a lot of ropinirole. There's another one called pramipexole. They stimulate the receptors, so they're not replacing dopamine. They have a moderately strong effect. They can be pretty good. The problem is their adverse effect profile. So nausea, postural hypotension also occur with these ones. Drowsiness can occur. Sleep attacks can be a problem. They can fall asleep extremely quickly, even if they're stopped at a red light or something in the car. That can be problematic. The main one, though, is the pathological behaviors and potential for psychosis. So people on these drugs, I've seen this several times now, someone who was started on it, not necessarily at our clinic, that has developed a compulsive gambling disorder or a compulsive disorder in the internet that is not constructive to their life. And it can cost their life savings because they will actually blow their money, or they'll spend all of their time on doing this thing that can destroy social relationships, for example. So this is ropinirole or the pramipexole. If you stop the drug, it usually gets better pretty quick. And so it's just be very cautious. These medications, I like to prescribe them in someone who doesn't seem prone to that, very stable, no mood disorders, no obsessions or compulsions. Not sure how many people are like that, how many of those kind of people are out there. MAOB inhibitors are okay. Selegiline, rasagiline is a little better than selegiline. These inhibit dopamine breakdown in the brain, not the blood, the brain. So not like the carbidopa and benserazide. They have a mild therapeutic effect. They're kind of weak, but their adverse effects are very kind as well. So usually you take them in the early morning. The main side effect is insomnia, but if you take it in the early morning, you minimize that. And I find them nice as an additive. Don't use them as sole therapy very often. Amantadine is a good one in some people. It's not a good one in other people. You just have to try it, it seems to me, and find out. It's an antiviral, technically. We don't know how it works, really. It has a mild to moderate therapeutic effect, but it's very powerfully, it can lessen dyskinesias, which can be a big benefit. And its side effects are not too bad, but they're not trivial. Livido reticularis, which is this lacy-like rash on the skin, is pretty harmless, but it can be very unsightly for a lot of people. They don't like it. And you can get agitation and insomnia and so on. So it's an option. COMT inhibitors and tecapone and tolcapone, these are older medications that I don't use very much at all. I think that we have better alternatives now. But basically, they inhibit dopamine breakdown in the blood and can improve those motor fluctuations by extending the length of time by which the Sinemet or other levodopa medication works. So you take them with the levodopa. So it means you got to take a lot of tablets throughout the day. If you're taking levodopa 4 times a day, you got to take this COMT inhibitor 4 times a day as well. It can worsen dyskinesias. There's a chance of liver toxicity with the tolcapone, and they can do other funny things. So I don't use these ones very much, but it's an option. Propranolol, again, another one I don't use more in the past. It's a beta blocker that can help the tremor. The trouble with it in Parkinson's is the side effects of propranolol are sort of the symptoms of Parkinson's. So the postural hypotension might get worse, the constipation might get worse, the fatigue might get worse. Obviously, these are extremely common in Parkinson's. I would not use propranolol unless you had a very strong reason to do so. And I thought about it. Well, as long as you think about these things, it's worth trying any of them in the right context. So that's a little chart if you want to come back to this talk later and just sort of look what the tablets look like. Often the patients will ask you about the blue and red tablet, and you will have no idea what they're referring to unless you have a chart. Okay, so for treating Parkinson's, it's best to focus on non-medication therapies first, I find, and always keeping in mind the motor symptoms, sleep, and mood are the things to focus on the most. So education is what you should focus on first. Discuss this disorder. Some people take it differently. Some people don't care. Some get annoyed. Some get sad. Some decide to tell everyone. Some tell no one. Some travel the world looking for a cure. It's quite variable. Figure out how your patient is going to take it, and just talk about the disorder, about some of the things we discussed, that this is what it is, and it's got these motor symptoms, it's got these non-motor symptoms. You need to be aware of all these things, really, and we can make you pretty good for a few years, and always be factual, but try to show that it's not all doom and gloom. And there should be a Parkinson's community educator. We have one for Waikato, obviously. It's an excellent idea to refer the patient to them, so they get plugged into the local Parkinson's community. Diet recommendations. Look, because of the scarcity of interventional trials, my main recommendation is to eat real food. If it has a label on it, it's not real. So if you go to the supermarket, broccoli doesn't have a label, steak doesn't have a label, right? You know the ingredients in there, it's real food. Anything with a label, which is most of the inside of the supermarket, not the outside, all the processed stuff is usually in the aisles, less of that. So more time on the outside of the supermarket, less on the inside. Remove the processed foods. And some people really do push for a low carb or ketogenic diet. And if they're interested and really, then despite the evidence not being strong enough yet, I'll help them start that. So that's an option. Exercise recommendations. Present all the options I showed you. We have pamphlets here which sort of go over them. And I ask people to just pick one and start once or twice a week. That's all you need to do, and get plugged in. Exercise can be very beneficial. I guess, exercise, a lot of the non-motor symptoms, like it's not just improving their balance in that, but exercise can help you sleep better. Exercise definitely addresses depression very powerfully, and so on. Okay, so this can help the non-motor symptoms quite a bit too. Deprescription is an important thing to consider. If there are medications that may be worsening motor symptoms, sleep, or mood, then remove them. And I would argue that as a physician nowadays in 2022, if you're not deprescribing on a fairly consistent basis, you're not doing your job. Doctors are trained to add medications, but we should be deprescribing to fight polypharmacy. This is a big problem. And additional medication therapies, you don't have to start these right away. You can give it 6 months to a year. It depends what the patient wants. Focus on the motor symptoms, sleep, and mood. If you focus on those things, that will be the best bang for your buck. Don't try to fix everything with Parkinson's, certainly not in the first 1 or 2 consults. It's just, there may be too much there. Just pick 2 or 3 problems and get them better, and then work on the next ones at the next consult. So motor symptoms, optimized levodopa is the best thing. That's by far the best medication, better than all the other ones by a mile. And really it's about timing the levodopa correctly, using the correct mix of immediate and controlled release, making sure the patient knows about the potential for food to interfere with it, and so on. If you do that correctly, you can get a lot out of your levodopa. And you can use all the other ones as needed. Just be careful with the dopamine agonists. Get someone to monitor that person so they don't go and blow their life savings in something. Sleep disruption. So again, the trick that I mentioned to you, I like at the start, just give a bit of immediate acting levodopa 1 hour before bedtime, and then you give a controlled release one at bedtime, and that's your best strategy. And again, because immediate release is 100% absorbed, 100 milligram of immediate release is actually not equal to 100 milligram of controlled release. You need more controlled release because it's only 2/3 absorbed. So you can go 100 of immediate release an hour before, and then a 200 of controlled release. You'll be a little heavy on control, but not by much, because it's only 140 or so of that's going to be absorbed. All right, so just remember that they're not dose equivalent. And that's good for the insomnia. For the REM sleep disorder, which is also extremely common, melatonin is okay, but clonazepam is the best. And you just start low and go slow. You can start at sort of like 0.25 or 0.5 milligrams at night. And that's probably the most effective way to address the REM sleep disorder. Mood disorders, you treat them like any other mood disorder. Antidepressants, anxiolytics, CBT, whatever strategy you would like to use. Now, for the other non-motor symptoms, this is all patient dependent. Everyone comes with a different kind of Parkinson's. You could do, these are just some examples for some other symptoms. It's by no means comprehensive. So if they have pain, optimizing levodopa can really help the pain. Often when the most of the pain occurs, any of those syndromes I mentioned, when they're off, when the levodopa levels are low. So you optimize levodopa, it helps. Exercise can help with the pain. Massage therapies can help with the pain. Postural hypotension. Don't just jump to medications. You can increase water and salt. A lot of people do not drink enough water, and a lot of people do not have enough salt. In Parkinson's, the main issue with blood pressure is generally hypotension, not hypertension. So you actually probably want to get them to increase their water and salt. Make sure those things are corrected before you jump into fludrocortisone and other blood pressure medications that raise the blood pressure. They're not always straightforward to use, but you can use them if you need to. Nocturia. So again, lifestyle habits. So if you're drinking lots of water during the day, then make sure you don't drink any more after 6 p.m., say, and don't have, coffee might be a good thing in Parkinson's. I'm not going to go against coffee. I love the stuff, but maybe none after 2 p.m. Simple things that some people don't realize. Reduce diuretics if you can. Oxybutynin can be tried. It may work, it may not. You can refer to a urologist to exclude a structural problem. Maybe it's not the Parkinson's. Maybe there's a structural issue there too. You want to be sure. Constipation. So constipation is very common in Parkinson's. Again, dehydration is the most common thing that results in constipation, bar none. So increase the water. You can get the fiber up. You can ask them to increase exercise. That can certainly help. Reduce any anticholinergics. You can prescribe laxatives and give enemas and stuff, but later on, try the other stuff first. Psychosis. Remove medications. Deprescribe. So I would leave. Some people are on like sort of amantadine and levodopa and a bit of ropinirole and blah blah blah. So just start taking them off one at a time. Go slowly. Make sure you don't freeze them up by taking everything off at the same time. Leave the levodopa to last because it is the best. And you can try an antipsychotic. You can add in quetiapine or clozapine if you want to have something more powerful. But just think about all these things. And it's not just about adding medications for Parkinson's. It's about removing medications. It's about giving them good advice on what Parkinson's is. It's about giving them advice on dietary modification, exercises, and so on. So there's a lot you can do here that's not just medication-based. Advanced treatments. I'm not going to go into too much in this talk, just to know that they're there. People who have Parkinson's for a number of years, and assuming all these things have been tried and the disorder is advancing, you can try different ways of administering a dopamine or dopamine agonist. Apomorphine is a little pump that they attach themselves, and they can sort of wear that throughout the day. Duodopa is, to my knowledge, still not available in New Zealand, at least for the majority of patients. And that's where the medication is injected directly into the duodenum, as the name implies. And deep brain stimulation, or DBS, is an option in a handful of patients, but you have to meet certain criteria. And they tend to be younger patients who do not have any depression, because DBS can worsen depression, and they have to have an excellent response to the medications. DBS won't work well unless they have a really good response. So there's a few other criteria, but if you have some patients are particularly suitable for one of these therapies, they can be very helpful. Okay, so to conclude, Parkinson's is a very complicated disorder, right? So it's a pathological process. Basically, the problem is the neuron loss. The problem is not necessarily the Lewy bodies. The problem is not the symptoms you see per se. The problem is that something is killing the neurons, and we still don't know what it is. So it's not just a movement disorder either, right? It affects neurons outside of structures that affect movement. So you get mood disorders, you get sleep disorders, you get pain disorders, and so on. It's a lot. The diagnosis is absolutely clinical. You have to identify what motor and non-motor symptoms are there. You look for signs such as bradykinesia, and the non-motor symptoms are usually the more disabling ones. You do have to exclude mimics. So that it means doing a little bit more on the examination, maybe a CT head and so on, but it is essentially clinical. And for most people, the largest impact will really, as I alluded to, come from focusing on probably motor symptoms, sleep, and mood, those three things in particular, and using a combined treatment approach that employs medications and non-medication strategies and information and knowledge. And honestly, you can make a huge difference to a person's life in 45 minutes if you do this correctly and then follow them up. And yeah, it's all about optimizing quality of life for as long as you can with Parkinson's. So thanks a lot.